All right, guys. We were trying to get to the end of hyperkalemia before switching gears over to hypokalemia. And I believe where we ended was on pseudohypoaldosteronism type 2, that is Gordon syndrome. Let's continue trucking along to other branches on the tree. And that next branch will be cases of hyperkalemia that have low aldosterone and generally high renin. I'll put it that way, generally high renin. So, as this summary statement says, we have low aldosterone in these set of causes of hyperkalemia. And then as you understand how to interpret aldosterone levels, I give you this information here that aldosterone levels should be interpreted contextually, meaning, don't just compare to the posted normals on the laboratory output. Just like PTH and a calcium should be assessed contextually, the same is true for aldosterone. And here's a bit of information that will allow you to interpret an aldosterone level when somebody is hyperkalemic. It comes from a paper that was published in JASN in both uh, moderately young people and older people. And it revealed that when challenged with a K load and increasing the serum K to roughly around 5, one should see an aldosterone level of around 20 in a normal or in a younger person, and maybe 10 in an older person. So it would be abnormal to have an aldosterone level in the single digits when somebody is hyperkalemic, even though if you look on a lab report, it would fall in a quote unquote normal range. So keep that in mind as you interpret values and assess cases of hyperkalemia. And these individuals often have a concomitant hyperchloremic metabolic acidosis. One of the main mechanisms of that is the hyperkalemia itself impairing the generation of urinary buffer, that is ammonium, one of your main urinary buffers for modulating acid excretion rates. Okay, so simply hyperkalemia itself is often a causal factor in the metabolic acidosis. There, of course, is also an effect on of low aldo on HATPase activity. So that would be another mechanism. Ammonogenesis impairment is a major mechanism. Okay, moving on to specific causes, we might find not uncommonly primary adrenal insufficiency. You'll recall, if it's primary, that you have a defect not just in aldosterone, but in glucocorticoid release as well. And so the diagnosis relies on interrogating glucocorticoid secretion. Okay. The clinical presentation of adrenal insufficiency can be fairly subtle and be manifest primarily in the context of a stress. And because we all should be able to elaborate cortisol in response to an acute stress. So, in the absence of an acute stressor, where the clinical presentation may be more obvious, you'll often have fairly subtle symptomatology, including just sort of a nonspecific failure to thrive. Okay. Now, the individual may have the electrolyte disturbances. However, they may not be manifest unless there's another process going on. We talked about, for instance, beta blockers as being a precipitant of hyperkalemia. But I told you that that shouldn't be the sole cause, but maybe adding a beta blocker to somebody who has primary adrenal insufficiency may unmask this possible diagnosis. Okay. Now, the non-specific symptoms of unwell being would be from the glucocorticoid deficiency, obviously the electrolyte abnormalities, and potentially some signs of volume depletion are a result of the mineralocorticoid deficiency. Diagnosis, again, is often revolving around cortisol production. However, I will highlight the fact that more and more, there is a measurement of this other steroid hormone that is considered a sex hormone, essentially a metabolite of a sex hormone, uh, because this has essentially a longer persistence in serum. So it's not so sensitive to sampling times where you can find a signal for abnormal glucocorticoid production by measuring other metabolites in this case, or other steroid hormones, in this case, DHEAS, because again, it has a prolonged half-life in comparison to cortisol. Okay, so drilling down to what you're looking for is you're trying to measure a cortisol in the early waking hours. So this could vary according to the sleep habits of the individual, but normally we should see after waking that there is a increase in cortisol production in the early waking hours. If you have a very low cortisol within a few hours of waking up, that would be presumptive evidence of a primary adrenal insufficiency. Okay. Now, again, one can use this DHEAS testing to also evaluate for the presence of an adrenal insufficiency. We should see low levels, right, in somebody who has uh, excuse me, this is a patient who will have high levels because ACTH will be high in individuals with primary adrenal insufficiency. So again, we're talking about primary adrenal insufficiency. So I've mentioned this before that ACTH, even though we simplify our understanding of ACTH and glucocorticoid homeostasis as being a fairly clean picture in which ACTH stimulates the production of cortisol. I mentioned to you in the past that ACTH actually has the effect of stimulating the production of multiple steroid hormones. And again, if I have a primary adrenal insufficiency, and uh, then yeah, I'm mistaking once again here. DHEAS is produced by your adrenal glands, so that would also be low if you had a primary adrenal insufficiency. That was, for instance, autoimmune in phenomenon. This would be something that you can also use to evaluate for secondary adrenal insufficiencies with ACTH defects, in which case you'll have low cortisol and low DHEAS. Okay, so I apologize for that several missteps here. Again, primary adrenal insufficiency would also have DHEAS being low because that's derived from the adrenal gland. Yes. How quickly does it come back? I don't order this much, so I couldn't intelligently speak to that. Cortisol. I guess you're saying that cortisol comes back relatively fast, and so yeah, so making the using DHEAS as a as a surrogate for evaluating adrenal response or adrenal function may not have as much benefit because it may take more time in comparison to cortisol. Yeah. So your point is well taken that again, you can do stimulation tests with ACTH to evaluate for adrenal insufficiency in the setting of these intermediate values that lie between the 3 in the morning or the 18 in the morning. So we are often using that as Naveen is alluding to. Okay. All right. So let's move on to etiologies, autoimmune phenomenon. are one of your more common causes of primary adrenal insufficiency. Sometimes that's in the setting of a polyglandular autoimmune syndrome that can also be associated with hypoparathyroidism, type 1 diabetes, for instance. But sometimes it's isolated to simply adrenal insufficiency or primary adrenal insufficiency. Infiltrative diseases, including cancers, infections. One of the most common worldwide causes of adrenal insufficiency is actually tuberculosis, occurring in the adrenal glands. One can have adrenal hemorrhage. It's one of the sort of manifestations of catastrophic infections in the ICU. Ketoconazole at high doses is a non-specific inhibitor to a lot of P450 enzyme systems, and because your adrenal synthetic pathway are all essentially P450 enzyme systems, ketoconazole can cause or precipitate an adrenal insufficiency, and is sometimes honestly used for certain cases of excess adrenal hormones, higher dose ketoconazole. Adrenal leukodystrophy is a unique inherited form of adrenal insufficiency. I won't belabor that point since it is pretty esoteric. We're going to talk in more detail about some of the congenital adrenal hyperplasias. This is a contrast to that set of discussions, this congenital adrenal hypoplasia, which again is another inherited form of adrenal insufficiency, again, somewhat esoteric, so I will not belabor that point. Okay, that's a nice segue over to congenital adrenal hyperplasias. There's a couple that are especially relevant to us, especially as we discussed the causes of secondary hypertension. Let's segue to that. I should have prepared more by splitting my screen so I can navigate a little quicker. But let's just march down here and then scroll backwards and forwards. 21 hydroxylase enzyme. Okay, I'll show you I guess let me do it. Okay. Your adrenal steroid biosynthetic pathway, to give you the visual here. Remember, your DHEAS is on this side of the biosynthetic pathway. Here is cholesterol, and then you make cortisol. You deactivated cortisone. We've talked about apparent mineralocorticoid excess. And then here you see your endpoint aldosterone. Now we have our 17-alpha hydroxylase deficiency. Here is a 21 hydroxylase deficiency, and as you can see, that would be upstream of the production of both cortisol as well as aldosterone, and so that would manifest as an apparent sort of primary adrenal insufficiency. Sex steroid hormone production would be intact. In fact, it might be upregulated in a male. You might see precocious puberty, for instance, and that is again because ACTH is driving the overall steroid synthetic pathway, and because I cannot essentially make cortisol, I have the overproduction of this limb of your steroid biosynthetic pathway. All right, so again, you can see I can't make cortisol or aldosterone if I have a 21 hydroxylase deficiency. Okay, now the presentation I alluded to, essentially, male infants would have or male or female, will have issues with failure to thrive and evidence of uh, uh, volume depletion. So dehydration, hyponatremia, and hyperkalemia would be predictably manifest. The overproduction of some of those steroid hormones would result in some genital ambiguity in the female patients. And then there would be some non-classical forms where there might be sort of more subtle deficiencies in cortisol or aldosterone production. Okay. The evaluation may be made at this point in time. We're doing a lot of genetic testing. So you can see, either excesses of some of these predictable sex hormone substrates and derivatives. And then you can also do genetic testing for the 21 hydroxylase gene. Moving on to another, again, place down this limb, hyperkalemia with low aldosterone. Renin will be variable according to the volume status of the patient, however, will tend to be elevated. That again is variable. If somebody is volume overloaded, you can suppress renin. Aldosterone deficiency is going to be the norm in these uh, this class of hyperkalemia. Um, ACE inhibitors and ARBs are going to be your most common cause of this form of hyperkalemia. Of course, we've talked about ad nauseum angiotensin 2 as being one of the stimuli of aldosterone synthase. Here are some mechanistic considerations that are highlighting this being a calcium-mediated signaling cascade. Heparin is another common one. It's not only sub-Q unfractionated heparin or infusions of unfractionated heparin, but sub-Q heparin and even low molecular heparin can be associated with a inhibition of aldosterone synthase. So aldosterone levels, again, will be relatively low, may not be low compared to what the lab says. Remember, again, compare it to what you should see in a setting of hyperkalemia. You should have aldos that are in the teens to 20s in most young people. If you allow for a less vigorous mineralocorticoid response in older patients, you should at least have double-digit aldosterone levels in the setting of hyperkalemia. So many of these patients with heparin-induced aldosterone synthase inhibition will have hyperkalemia with an aldo of like 6 or 7. That is abnormal. Okay. So again, that's one that's common that we see in the inpatient setting because heparin and low molecular weight heparin are common. If you see this, you have to, and you still need anticoagulation, you need to switch to fundaparinux as an alternative. If, for instance, you're not interested in full dose anticoagulation or the DOACs, for instance. Okay. Um, Critical illness can be associated with just a relative adrenal insufficiency. And then you can have aldosterone synthase mutations, and soon you're going to be able to prescribe aldosterone synthase inhibitors where aldo will be low. Okay. There's a New England Journal paper on this new class of blood pressure medications. And I'm sure marketing is going to, already marketing is following pretty hard. Why you would prescribe it over just a mineralocorticoid antagonist, I'm not sure. Moving on, hyperkalemia can also be associated with low renin. Okay, low renin, so upstream, and low aldosterone. All right, same deal as before, that we should see aldos of around 10 to 20 in somebody who has hyperkalemia. This branch of causes of hyperkalemia would similarly have relatively low, contextually low, let's put it, aldosterone levels. Okay, same statement about the cause of metabolic acidosis. Primarily, it's an issue with production of ammonium. Many times, let me make this point, many times these patients with low renin, low aldo, or just low aldo and even high renin, if you correct the hyperkalemia, the metabolic acidosis often corrects without giving sodium bicarbonate. Okay, this is an important point, and we'll highlight it again when we talk about type 4 RTAs in our acidosis discussion. So again, correcting hyperkalemia is an important mechanism of addressing metabolic acidosis, even before, if it's possible, even before you add sodium bicarbonate. Diabetes mellitus is the most common context in which this low renin, low aldo occurs. We typically give it the label type 4 RTA. Why is it specifically that diabetes is associated with this is not well known, okay? Often it's not just diabetes, but the patient will often have a mild degree of CKD, and then you'll just think to yourself, well, why would a patient with a creatinine of 1.3, who typically tolerates an ACE inhibitor, can't tolerate an ACE inhibitor because of hyperkalemia? That's the classic presentation of this form of hyperkalemia, a disproportionate hyperkalemia in somebody with relatively mild CKD, usually underlying diabetes. That being said, I've certainly done e-consults on plenty of patients who have totally normal or apparently normal GFRs, just have diabetes and have this predisposition to persistent subtle hyperkalemia. Okay. So again, it often coexists with mild CKD, but doesn't have to. There is some description of diabetes itself causing some direct dysfunction of the granular cells in the wall of the afferent arteriole. But again, this is not well described or well hashed out mechanism. Okay. There's often a degree of volume overload in these patients, right? That's why I said that, well, excuse me, I've already characterized these as low renin, low aldose, but there is often a degree of volume overload in this patient population, which makes the tool of fludrocortisone a, a tool that you should be very cautious about prescribing. You might say, again, these patients have low aldo. Let's give them a mineralocorticoid. The prescribable form of mineralocorticoid is fludrocortisone. So you'll be tempted to do that. They already are predisposed to volume overload. In fact, some people espouse that's one of the causal factors in the hyporeninемia in these patients, that mild CKD and diabetes and diabetic nephropathy predisposes to chronic volume expansion. And then you get sort of an atrophy of the renin secreting cells in the afferent arteriole because they're always turned off. The patient is chronically volume overloaded. Okay, does that make sense? Okay. All right. So again, these patients are already predisposed to volume overload. Putting them on fludrocortisone can precipitate volume overload, and so that should be an option of last resort. Okay. Obviously, you're going to try diet first, diet and diuretics, and now we have another tool, the chronic use of potassium binding resins like Lokelma. So those are what we're using typically. All right. So let's move on to another common cause of hyporeninemic hypoaldosteronism, and that's nonsteroidals. We've gone over a number of effects on nonsteroidals. Remember, it potentiates the effect of vasopressin, causing a water retention. That water retention will be predisposing the individual to hyponatremia, but it also causes a mineralocorticoid deficiency, which will predispose to hyperkalemia. Okay, so these individuals, yeah, so these individuals again will have a hyporeninemic hypoaldosteronism. Here is some greater detail on the mechanisms that are revolving around the complex homeostasis that is centered around prostaglandin production on various aspects of renal physiology. Prostaglandins, as I mentioned, affect vascular tone, salt handling as well in both directions, natriuresis and antinatriuresis. So it's again a complex set of downstream effects on nonsteroidals. The sum total, however, is a hyporeninemic hypoaldosteronism. Okay, beta blockers we already discussed can inhibit renin release through their effects on the beta 1 receptor. Remember, non-selective beta blockers can cause hyperkalemia through transcellular shift, that is impairing sodium potassium ATPase activity. We've gone over that. Sodium potassium ATPase activity. That would cause extracellular K excess, not a total body K excess, extracellular K excess, right? But you can also have a total body K excess through the effect of beta blockers on the beta 1 receptor, decreasing renin release, causing a hyporeninemic hypoaldosteronism. All right, so to round this off, we'll just return real quickly to the algorithm that we started with, or that is at the top of the chapter. Again, we're looking at yeah, I guess I did not put in here the use of mineralocorticoid antagonists here, or did I upstairs? Yeah, I did that upstairs through the mineralocorticoid resistance. Okay, so here we are. Again, tubular resistance to aldosterone we previously discussed. The use of mineralocorticoid antagonists or ENaC channel blockers, including those that are off target, triamterene and pentamidine. These are off target inhibitors of ENaC channel activity. I think we talked about sickle cell already last week as a tubular interstitial disease that causes a impaired aldosterone responsiveness. This is a defect in mineralocorticoid receptors. And then we're looking at aldosterone itself in a contextual way. When we're interpreting the aldosterone levels, we have individuals that can have low renin, low aldo, beta blockers, and nonsteroidals would be examples of that. The type 4 RTA that occurs in the diabetic is another example of that. And then we have these final causes of patients with hyperkalemia. These are individuals that let me round out this gap here. High renin, low aldo are the discussions that we already covered. Heparin being one of them, ketoconazole being another, congenital adrenal hyperplasia, as well as the hypoplasias that cause combined glucocorticoid and mineralocorticoid deficiency, which we covered in the text. And then I think we've already, in a problem set, covered the fact that Gordon syndrome would have variable aldosterone levels. On the one hand, the volume expansion lowers aldo. On the other hand, the hyperkalemia stimulates aldo release.